Hi, everybody. Welcome
Good
to our
night.
community. Welcome to our community workshop for the Center for Learning Disabilities at West Texas A&M. We're so excited to have you here today. I see a huge crowd, which is understandable because we all want to learn about how we can really best use medication to help some of our students with ADHD. So I'm going to introduce our speaker. Our speaker is Dr. Parker, and you'll see him because he has that wonderful bookcase behind him. So our speaker tonight is Dr. Parker. He's a faculty member in the Pediatrics Division of Texas Tech University Health Sciences Center, School of Pharmacy, and School of Medicine. He's been there for 17 years, and he also teaches in the Physician's Assistants Program. In addition to teaching, he's a clinical specialist for the School of Medicine. And in addition to that, he also practices as a provider in the pediatric ambulatory care clinics in Amarillo. So welcome, Dr. Parker. We're so happy to have you here tonight.
Thank you very much. I'm happy to be here. I was saying earlier, I'm trying to get a little bit energy going. It's been a long day. For many of you, it's probably been a long day. And so I'm going to pull my slides up while you guys maybe get your dinner or get a snack or get some beverage. Hopefully I won't put you to sleep. I'll try my best not to. If this was live, I'd run around the room a lot, but that won't happen here. Or if I do, I'll just I might get away from my computer too far if I start walking around. So let me see if I can open this up. Need to shrink it a little bit. All right. So is that showing up the way it's supposed to show up? All right. So today we're going to just touch base on ADHD. Obviously, most people have heard of that now. I did this talk about 4 years ago, and if you were there or watched the videos, the slides haven't changed a whole lot because a lot of new stuff hasn't come out as far as our approach. But what has changed are we have some newer medications, and we're kind of targeting things a little bit differently. So that's a good thing. It's actually stuff that I talked about in the talk 4 or 5 years ago, that some of these things were underdone and now we're starting to do them more. So it's nice to see that we are making some transition. A lot of people are interested for many reasons, maybe because you yourself have dealt with this, or you're a caregiver of someone, or you've interacted with people, or if you're in an educational setting, the same kind of thing. So it's pretty prevalent, the awareness of this. And it's actually kind of surprising that the stats say it's only about 10% of kids, because it sure seems like there's a lot more talk going on about this, and it carries a lot more weight than you would think of just 10% of our kids dealing with ADHD. And so tonight, I'm going to try to be as factual as possible. One of the big challenges, I think, with any kind of psychological disorder is, unlike other medical things, there's no lab test for a lot of this stuff. There's no cuff that you can put on someone and measure. There's no thermometer for it. There's no blood test. And so a lot of it is opinion. And, opinion doesn't always fly well out in the world. And so you do see some differences of thought with ADHD. Different directions that different experts want to go. And so I don't stand on either side of any fence. I'm just going to give you the facts and talk about what different groups think and how it opposes to other groups, so that you guys can make your own decisions, which is usually the most important thing, is having an awareness on your own and not necessarily trusting blindly in really anybody in medicine. And so when we start off, I'm going to really focus on 3 things. I'm going to briefly kind of remind us how it's diagnosed and how we should do this in a more objective, consistent way. Additionally, I'm really going to talk about the medications we use and why we use them and some of the things we need to pay attention to. And then lastly, I'm going to kind of talk about some unique things about the medications that most kids are on that many people aren't aware of. And even a lot of providers don't know the nuances that can maybe make those medications work better for certain patients. So that's kind of the gist of where I'm headed. I don't mind being interrupted. I don't really follow a script or a format. So go ahead and ask questions throughout. And that way I can see them and maybe direct some of my comments and presentation towards those questions. And so, as I mentioned, it's about 10% of a prevalence. What's kind of interesting to me when I was looking at the more recent data is that we've actually had a decline in a lot of parts of the United States, and in Texas, we have less kids being treated this year for ADHD than it was back when I did this talk about 5 years ago. Not much less, but less. And so that could be, we've done a better job of diagnosing and finding other disease states that were being misdiagnosed as ADHD. It could be a different philosophy of how we're treating with ADHD meds. So I'm not really sure why it's changed, but it has changed. When we talk about ADHD, it's about attention and impulsivity. And so when we talk about diagnosing it, it tends to fall into those categories. And so these are kind of the common things you might look for when we're looking at symptoms that can be related to ADHD. And one of the things to be aware of is that most of these are pretty common things you'd see in a kid. And so that makes it more challenging. I mean, do kids move around and talk? Sure. Are they fidgety? Sure. And so that's where the diagnosis becomes a little muddied. And that's why we have kind of pretty specific criteria that we want to meet all of to really say it's ADHD and not just kids being kids. And so we look at these lists and we identify things that we might see a child embarking on or having these things happen to them. And then we kind of categorize it. So the diagnostic criteria are that you need to have at least 6 of those in either category, any kind of mixing and matching or more of those symptoms distinct, and they need to have been going on for more than 6 months. Okay, so it's not just one symptom. It's not one symptom randomly. It's like consistent problems in those areas in 6 areas or more over 6 months or longer, and at an early age, before adolescence. When kids get 12 or they get into adolescence, it can confuse things because we know adolescence itself. I mean, my gosh, I have 2 adolescents, and they have no attention when I'm talking to them. So adolescence really muddies the water. So we want to see these things present before adolescence. And probably one of the bigger ones, especially for someone on the outside, maybe not the patient themselves or not even the parent, but when we have caregivers and we have scholastic folks that might be seeing these kids in an environment and concerned about them, we have to recognize it has to be in more than one environment. So 2 or more settings have to have these impairments happening. So if someone's bratty at school, but an angel at home, maybe not ADHD, maybe something else, okay? That kind of scenario. So we want to see it in multiple settings over an extended period of time at an early age. And probably the 2 that get
Excuse me, Dr. Parker.
Yeah.
I'm so sorry to interrupt you.
No.
We're seeing your slide, but we're just seeing the first slide. So I think that there might be, I think if you can get into presenter mode, then we can see as you progress through.
No, am I not in presenter mode? Maybe it's because when I shared it, it wasn't in presenter mode. I think that's what. Let's try this. Man, I got 3 slides in before you told me.
Well, I heard you talking about the comparison of the 2 groups, and that's what clued me in. I could see it. See it waiting for us.
This is the right one.
Excellent.
Okay.
Thank you so much.
Let's make sure it moves. Did it move?
Yes, it did.
Okay. All right. So this is where I was. So these are the domains of many of the things. Some are considered hyperactive things. Some are considered lack of attention things. And then I'll bring us back to where I was really talking about, which was the diagnostic criteria. So technically, all 6 of these criteria have to be met. So a lot of symptoms, more than one environment it's impacting, an extended period of time, and a younger age. And then, like I was saying, the last 2, which I've highlighted in yellow, are the ones that I think get neglected, especially if it's not a specialist diagnosing. And the Academy of Pediatrics, they've published their own recommendations that are in line with what the psychology community kind of views. And one of the big statements they said is they recognize that there aren't enough qualified or specialized people to deal with this, though. So they expect general providers to do it, but that also puts the general providers at a disadvantage because they don't necessarily always haven't been trained up on all the nuances. And so these would be 2 that I think often get left beside, which is it actually have to have these symptoms have a negative impact on the child's development and approach to life. In other words, if a student's still getting A's, then it may not really be ADHD. They might have some of those other symptoms, but it's not impairing them in their success. So, and the reason it's so important that we highlight the students or kids with ADHD is because we see a lot of misdiagnosis in this. And if you Google things, you'll see that people say we underdiagnose, we overdiagnose. We actually are diagnosing the wrong disease. And those are all probably true because it is somewhat subjective. And so if they have another underlying condition, we hopefully would diagnose it and not call it ADHD, because we're going to talk about the treatments are not necessarily appropriate for other things. But also the kids who really have ADHD, we don't want to miss that. And we really want to help them out. And I've seen real wide extremes of ADHD in children and how it impacts them. And so we don't want to neglect the ones that truly need this. And so that's why having an objective approach really is important. And then the last thing is and we're going to talk about this later, is the occurrence of other psychiatric disorders that may present similar to ADHD, but aren't ADHD. And there are quite a few. So that's just a background. We're not going to be diagnosing anybody today, so we don't really need to go in depth, but to understand that there is an approach that tries to make it fairly consistent so that we can catch the folks that really need it without overburdening our children with treatments that aren't really tailored to what their needs are. I got to do this. There we go. Okay. Now, I'm not going to get super sciencey, but I do want to point this out that obviously we're dealing with brain function, okay? And there are two main areas that we're dealing with: is the attention, how we manifest our attention on things, and how we behave. Well, it turns out there's two big chemicals that are responsible for that, and it's norepinephrine and dopamine. And I bring that up because when we talk about the medications and treatments, that's where the targets are. And so that's the only reason I'm throwing this in there, is that to get the signals where they're supposed to be, to tell us to kind of do things the way that would be better for us from a focus and behavior point of view, we rely on dopamine and norepinephrine. And so ADHD, the theory is that there's a disruption there. The amount of dopamine and norepinephrine is not appropriate for the child's needs. And so the medications target those two chemicals. I keep trying to space bar and it's not working. Okay, so when we first start about treatment, we're going to obviously start with the non-pharmacologic management, all right? Now, there isn't a ton with ADHD. We have behavioral therapy, and there's some different methods there. Now, in all honesty, there's behavioral therapy for a lot of different psychological disorders, but ADHD, it's maybe not as impactful as it is in some other things, like with regards to counseling. This isn't really a counseling type scenario. It's more about learning skill sets to help you appropriately focus, kind of things like that. So it's more skill training than it is like counseling. And so it does have positive evidence for its benefit, but maybe not as strong as some of the other conditions that we typically think of behavioral therapy for. And that's why typically it's not used by itself in standard children. The only place we do it really by itself is in our youngest children, where we don't like to start the meds yet, and that's under 6. So if they're under 6, we do go to behavioral therapy by itself first. You can do behavioral therapy by itself in older children. It just is not where most people land. They typically go to the medications with or without the behavioral therapy. But it can be impactful, especially in combination. And it can really help with some of the bigger problems that we run into with ADHD, especially if it's uncontrolled, with some of these substance abuse and some of the overarching attention issues like delinquency and things like that. So it does have an impact. It's just really underused for ADHD here in the United States. Now, the typical go-to is drug therapy, medications, all right? And so this is going to be the weight of what we're talking about. And so when we think about medications for ADHD, they typically fall in two big categories, okay? Stimulants, so amphetamines and methylphenidates, and then the non-stimulants. And there's a whole range of non-stimulants. And most of these medications really are in other classes that were maybe not originally even designed for ADHD, but maybe to treat other disease states. And we found that they worked in ADHD. And so we have these two kind of categories. And this is another place where there's sometimes some controversy. Stimulants tend to be the front line, and we'll talk about that in a minute, but they are a controlled substance. And in fact, they're the highest level of controlled substance by the DEA, except for illegal drugs. So the only thing that is more controlled than this particular class of medications are illicit illegal drugs. And so that's concerning, right? That we're using a drug that has that high category, and it has that category for a reason, because these are drugs that can be abused and cause addictive things and stuff like that. So there is a concern with using stimulants, a valid concern. Now, the way we use them for this is not the same way someone's going to use them illicitly, much smaller doses, and the mechanism, how the pills are put together are a little bit more controlled, but nonetheless, it comes from those same family of medications, where the non-stimulants don't really have that. And so you get kind of two schools of thought when you're dealing with these medications and prescribing them for children with ADHD. Okay, and so I want to keep that in mind, that we have these two major classes. All right. Now, when we start to use these classes, stimulants typically are the way that are recommended to go. And so let's just talk a little bit about how we typically approach this. Someone gets diagnosed because of all those criteria with ADHD. And then the frontline medication is going to be a stimulant. It's either going to be a methylphenidate or an amphetamine. Okay. Now, the guidelines say that you should pick one of those, and there's several drugs in each of those categories. And you pick one, and you started a patient on it, and then you see if you get a response. If you get any kind of positive response at all, you stick with that class of drugs, and maybe you just adjust dose and things like that to get exactly where you want to be. If for some reason that drug class didn't give you much positive effect at all, the recommendation is to still stick with stimulants, but pick one from the other drug class. So if you started with amphetamines, you try a methylphenidate. If you started with a methylphenidate, you try an amphetamine, all right? And then they do that. Now, the reason that is where the recommendation goes is because the evidence says that over 90% of patients with ADHD will be successful with one of those two options, all right? So high percentage chance of success, which in medicine is what we're always trying to do, highest percentage chance of success. All right, then you tweak that one. If neither of those options work, that's where the non-stimulants typically come into play. All right, now, notice that little dotted line there that says you could not go the stimulant route if there's a reason to not use a stimulant, which we'll talk about in a minute, or if the patient or caregivers don't want to use a stimulant. All right, and this goes to where that controversy lies. So in medicine, we typically do these kind of algorithms to kind of make sure everybody's on the same page for treating things, but they typically fall in two kinds of categories. All right. They fall into, you have time to fix the problem. It's not immediate. It's not life-threatening. It's not emergent. And so we typically start with what we consider the safest medications that have benefit and try them first. And if they don't work, we go to the more risky medications. All right. But then we have another school of thought that says if it is life-threatening, if it's something that needs to be fixed really quickly, we just jump on what the most effective drug is, even if it has a lot of risk, because the risk of doing nothing might be worse. That's what this algorithm is, and that's why some people don't like it. They're saying, why are we in such a rush to fix the problem using the drug class that you're going to see has the highest risk to it? And so that's where some of the controversy is. And the simple answer to that is they say, because we know it's going to work. And even though it's maybe a riskier med, it still isn't that risky a med. And that's valid. We don't see a ton of problems with stimulants. They do have some, but it's not overshadowing. We can focus on some of the small percentage chance of some of the really bad things. That's true. And which is why we need to really pay attention to our patients' individual issues to know if it's a really good choice for them. But that's where the controversy tends to lie. Some people really think we should have non-stimulants first because it's a safer approach, and they are still fairly successful. And other people are very satisfied going the stimulant route because we haven't had a lot of problems with it. So let's talk about the drugs in those classes so we can see what the real challenges are, whether it's stimulant or non-stimulant. And I know there's a lot of chat stuff. Any questions so far? Because I don't mind pausing or answer anything in the middle.
We had one question or comment from Siobhan. Siobhan, would you like to go ahead and make your comment here?
Is this the one about, let me see here.
Yeah, the participant commented
Oh,
that.
good night. Good night. Good night. You hearing me, miss?
Is this Jamaica? What I don't see in Jamaica is the resource and the affordability by family.
Yeah, good night. You hear me? Hello?
Hello?
Yeah, you hear me now?
We can hear you.
Yes, we're
Oh,
able to hear you.
so I'm saying in Jamaica, good night again, good night, everyone. I'm saying in Jamaica that the resource to treat ADH, we really don't have the resource or we deal with that, especially in a country like us where our classroom population, especially at the pre-level, are not equipped to deal with it.
Phonic blending is the ability to hear the individual sounds in a word and then putting the sounds together, right, to form the word that is made.
I feel like I lost part of that at the end. So it was dealing with the resources, like, and so not
Yes.
having. We talk about like the
Again,
were we talking about the medication resources, or are we talking about maybe the behavioral side, or even the diagnostic side? Well, let me talk about the medications because there might be some solutions in there, because obviously from a resource point of view, the mainstay, these stimulants, often are probably the ones that would be the most expensive and hardest to procure. But there are other options of more common, fairly cheap drugs, as well as the behavior side that can be beneficial. And honestly, the behavior stuff is, like I said, it's not counseling. There's some basic skill sets, even for parents to reinforce. And so a lot of those can be beneficial. They're just really underutilized, but they're fairly straightforward once you can educate parents on what they need to do with kids and stuff like that. So maybe we can talk about that in just a second. Just a reminder that once again, in children, we don't go to the stimulants right away. In the small kids under 6, we try the behavioral therapy, exactly what I'm talking about, where a lot of it's parents go to a session, learn how to do it, and then try to reinforce these behaviors in their children. If we had to go to medication, we're going to use methylphenidate, which is a stimulant, but it's the shortest acting one. We don't like to use long acting medications really for any disease state in kids until we kind of know what's going on, because it's harder to reverse if we're wrong. So as we talk about stimulants, so once again, they have a really high response rate of being effective. They work on both pathways of that dopamine and norepinephrine. So that's why they're the kind of the go-to med for a lot of folks. But once again, they may not be perfect for every patient. And so let's talk about some of the issues. Number one, they have a big warning on them, because I already said they have a drug dependency or abuse warning, and they are the highest level of control, which makes them challenging to get here, even in the States where you have to go through special prescription regimen, like they have to be written a certain way. They can, the amount of refills is limited, things like that, if they can be refilled at all, depending on the state. So it's a process challenge, but also it also is this class of drugs that does have the potential, small potential, but a potential to cause some major problems. Probably the other big thing with it is these are stimulants. So they stimulate the whole body, meaning the cardiovascular system. So there's this concern. We do see high blood pressure, we see increased heart rate, and there is this small chance of pretty severe cardiovascular events like stroke or heart attack and things like that. Now, once again, a pretty small chance, but a chance nonetheless. The more common things you see are the typical medicine stuff like an upset stomach. Now, because these are stimulants, they function as appetite suppression, so we can see weight loss. Now, I could use a little weight loss myself, but kids need to have weight in order to grow. So in addition to weight loss, we do see a reduction in height as well in most kids with ADHD. Now, it's not overwhelming, but it doesn't come back. And so it does have a high chance of reducing the final height of a child if they're on these meds. The longer they're on the meds, up to 3 years, it kind of adds. And then you kind of see some of those heart things like hypertension, headache. Those are related to that cardiovascular side effect side. And they may not sleep a lot either, which also affects growth. So there are some definite issues with this. And when I see kids with this, that's probably where they come in the most. The things that parents are saying to me or caregivers are saying to me is like, he or she doesn't eat. We can't get them to eat anything. They're never hungry. Or they're not hungry all day, and then they eat a whole bunch like right before they go to bed, and then they can't sleep. And so those are the kinds of things that we run into when we use the stimulants. And once again, there are some serious things that are fairly rare, but we can't ignore them. And that would be that cardiac death issue, but also because they're stimulants and the way they work on both those pathways, they can actually cause other psychiatric problems to get worse. Okay. And so when we look at stimulants from those side effect point of view, what can we do about it? Because they're still the go-to med, and you're going to have a lot of kids on them. What else can we do to kind of compensate for those side effects? Well, number one, the appetite and weight loss. When we take these stimulants, they kick in, they work strong, and then they go away. So we need to sometimes time our eating around when they are not as effective so that we have more of an appetite. So altering our eating schedule can help with the weight loss and reduced appetite. The sleeping, obviously, they're a stimulant. The whole point in the day is to add focus, but if they're lasting too long, it might carry overnight. So this is going to be at the end of my talk where I talk about how not all these meds are equal. You have to find the right one that matches your daily schedule, because sometimes they're stronger, longer than we want. Taking with food can help with the GI effect. The next three are all related to that cardiovascular side. And so what we want to do is maybe just use just enough dose to get the effect we want without adding that side effect. So the solution to the headache, the irritability, some of the abnormal tics and movements would be getting to the lowest dose possible that helps us out. Or if that's not possible, we might need to go to a non-stimulant. The last one's really just for people who use a patch. Sometimes if you use one of the patches, it can change the color of your skin. So we would have to change to a different medication. But there are some things we can do to help compensate for the side effects, because once again, stimulants are typically what's prescribed, and they are pretty effective if you can deal with the side effects. Now, obviously, if the side effects are so big or you just have a concern with them, then we have the non-stimulant route, which is where we're going to go next. So the non-stimulants, they're all going to work on the norepinephrine side. So they don't necessarily do both dopamine and norepinephrine, which is why maybe they're not quite as effective. But I'll tell you, and this is probably one of the places we've seen the biggest change, is in this category, which SNRI simply stands for selective norepinephrine reuptake inhibitor. So this is a class of meds that works on norepinephrine. And these two were specifically designed for ADHD. Okay, so they were designed for it to be a non-stimulant that still works on that pathway. And they do a decent job. So you can see the success rate somewhere between 60 and 80%. So maybe it's not 90%, but I mean, it's over half. That means half the kids you try might be successful in this and didn't need a stimulant. So once again, this is where some people are saying you should consider trying a non-stimulant first. That's not necessarily what the guidelines say and what most providers do, but it is an option if that's what the caretaker wants. You have that option, so know that you have those options. They're not benign, okay? So they still are going to have some side effects, but they have a really good place in therapy. Now, you can wait until the stimulants don't work in that last 10% of people and try it in there, or maybe you go here first if you're concerned about that substance abuse thing. Maybe it's a child who already has some kind of that inclination to have addictive personality, we might say, where you're concerned that they might fall into that trap. You don't want to do stimulants. There's lots of valid reasons. We talked about cardiac. We talked about its controlled substance. Maybe that's the reason. So this would be a good place to start. And one of the ones I really want to focus on is also having anxiety. Okay. And so we said that there's a lot of other mental disorders that can be mistaken for ADHD or happen with it, and stimulants may not be best for. Well, this med not only can help ADHD, it can help anxiety. So if you have both, it's 2 for 1, which is what we like. And so there may be situations to use this first line and some of these other non-stimulants first line when there are other things going on. And that's the next thing we really want to talk about, is the fact that there's almost always something going on. So they found, and this is just what's been reported, that over 60% of kids who have ADHD also have something else going on. The top one are behavior or conductive problems. So conduct like oppositional disorder, behavioral disorder. So things where OCD, anxiety, depression. And I'll be honest, this stat's a little old. I wouldn't be surprised if anxiety and depression are higher now in kids because of a lot of things that happened over the last 4 years. We are seeing a rise in anxiety and depression in our kids. So if these kids most likely have another thing going on, and if that's the case, then stimulants are probably not the best choice. So when we say a stimulant is frontline, we're really talking about ADHD by itself. If for some reason, and in 60% of the kids, it's probably the case, they got something else in addition to ADHD, non-stimulants may really be the preferred. And I think that's the part that we have historically kind of forgotten about, but we've seen that change a little bit, where we're paying more attention to these other disease states. And so that's why maybe these other meds are a little bit more beneficial. So for example, those two meds that I just mentioned that work on norepinephrine, the norepinephrine pathway, there's a lot of antidepressants that work on that pathway. So it makes sense that that med, while it works for ADHD, is going to help with depression and anxiety and some of these others. So that's going to be a better choice. And so once again, we have to do our due diligence and really look for these other things. So let's talk about some other non-stimulant, or let's finish that one and talk about some other non-stimulants. There are some problems with it. It does have a black box warning. And in this case, it's not for the abuse potential or the cardiac side. It's for suicidal ideation. Now, this occurred in way less than 1% of the patients that they looked at. And what it was, they found it wasn't a causative thing. They found that it was more related to children dealing with depression and other things. And this is a very common warning with antidepressants for patients with depression, because if they have depression, once you start treating that depression, things start to change a little bit, even though it's not fully there. And so there's this kind of time period where there's some suicidal tendencies might start to rise until the depression is fully kind of addressed. And so that's where they believe this comes from, because it's similar to an antidepressant in that way. So that, that still could be concerning. It's benign. It's not benign, but it's maybe not as severe as we see with the stimulants when we come to the side effects. A lot of the same side effects here occur here too. Maybe there's some appetite, maybe there's some weight loss, but way less than the stimulants. There might be some blood pressure or heart rate changes, but way less than the stimulants. So in general, these tend to have lower side effects and a little bit more safety profile, which is, once again, they're non-stimulants and they don't have that control on them. So what do we think about these? Okay, they're an option. They might be a preferred option if there's additional things. The nice thing about them is when we're going to see that how you dose the stimulants matters, but here it's really just kind of a once a day thing, maybe twice a day for Strattera on some patients. So you don't have to, it's not as time sensitive of when you take the dose as it is with the stimulants. Now it takes a little longer to get the effect. The stimulants, you can see that effect very quickly. You'll get some effect the first day you take it. You'll get most of the effect within a week, where here you're going to have to take it for about a month to really see the full benefit. So some people don't want to wait that long. So that's once again a reason people tend to go stimulants, because they're faster. They're metabolized by different pathways there, because there are some interactions with other meds. Now, most of the meds that these two particular medications interact with are not very common meds. And so it's not something you're going to run into likely. But the important thing here is that if you're on Strattera and you start to take maybe an antidepressant that it can interact with, you switch to the other one because they are processed differently by the body. So they do not have the same interaction. So you can go one or you can switch to the other if you have a problem with one with interaction. So that gives you some versatility there. And Quellbri is brand new, just a few years old. So it's having really good success, probably more so than Strattera. So that's where one change has happened. We're seeing more use of this SNRI category than we did like 4 or 5 years ago when I gave this talk previously. Alpha-2 agonists. So these are blood pressure meds. Okay, so clonidine, guanfacine, they're blood pressure meds. They've been around for a really long time. They're not even blood pressure meds we use anymore. Okay, so these are super cheap. They're like those $2 meds that you get. And it turns out they weren't very good for blood pressure, but they actually work pretty decently for ADHD, because once again, they work on that norepinephrine thing. And so these have been around for a while. As we've done research, we found that they actually are fairly selective for ADHD, some of the places in the brain. So that's why they've been kind of they've had a revitalization. They've been remarketed and branded for ADHD, where they used to be for blood pressure. They maybe are not as effective as the previous things we've talked about, but they can help some kids. And especially, once again, kids with other things going on, like that aggressive oppositional disorder or tics, because these are kind of a calming medication in a sense. Because of that blood pressure lowering effect. Anybody who's been on blood pressure meds know it kind of, I don't want to say sedates, but it kind of calms you down. People take blood pressure meds when they want to speak in front of a large audience because it calms their nerves. So kids who have those kind of problems in addition to their ADHD, these kind of can work well. They have that kind of calming effect. And once again, it's guanfacine and clonidine. They don't have a really broad side effect profile. Maybe a little bit of the blood pressure side, like with the low blood pressure or tiredness or headache. We do have to pay attention to blood pressure when you're on them. Now, the doses we use are smaller than would have been used to control blood pressure, but it could technically have an effect by lowering the blood pressure too much. That's probably the big thing. The only other big thing is clonidine does have a lot of interactions with other meds. But these are very cheap, readily available, and could be a starting place if you don't want to go with the more expensive or the stimulant route. Here's just a kind of summary of that. They come in both quick release as well as delayed release, meaning they're going to last a little longer. I'll be honest, that's a little bit of a marketing thing. They both, even in the immediate release, they last a pretty long time. So it's not like something that's only going to be like 4 or 5 hours. It's just you may have to take a little bit less, but typically you're still taking them once a day regardless. You just get a little bit more effect from the long-acting versions. And the clonidine, you can use the patch. You don't see it used a lot just for ADHD in the patch form, but sometimes if you're dealing with that aggressive or compulsive behavior, they do use the patch for that, and so it kind of double dips if ADHD is also an issue. So patch may be a little less often just for straight ADHD, but can be used if you're trying to treat two different disease states. But guanfacine is actually considered the better choice. It's a little bit more effective in ADHD than clonidine, but they're pretty similar. Okay, once again, those were pretty common old meds that have been around a while, just not used for ADHD until really the last, 10 years or so. Here's some ones that you don't see used as often, but technically could be used. Now, I will say, not that I don't know if anybody's a prescriber here, but these are off-label, so meaning they don't have an indication for ADHD. We just have seen them in studies used for ADHD, so we know that there's some evidence there. Wellbutrin is often used for like smoking cessation and things like that. So once again, kind of that compulsive behavior. And so it can help with ADHD in addition to compulsive behavior. Once again, trying to double dip there. TCAs, with all the new non-stimulants available, we're probably going to see very little of them used. Those are antidepressants. So we talked about that depressive side of things, but they're also not very good antidepressants. They have a lot of side effects and interactions too. So they're kind of old antidepressants that we don't even really use for depression as much anymore. But they technically could help someone with ADHD. So we've got all these options now. All right. So we have the stimulant route, which is the recommended way to go because you get quick, very good effect. Okay. But it has some risks. And it really depends on the patient whether you feel those risks are overwhelming or not. But we do have a lot more options than we've ever had before in the non-stimulant route. So that's good. Primarily, you're going to look at those non-stimulants I first talked about that were really designed for ADHD, that are those norepinephrine drugs, Strattera and Quellbree, because they are designed specifically for ADHD. They target that mechanism. They have some side effects potential, but not really high level of side effects, but there's always risk. But they have a pretty good success rate. They're almost as good as the stimulants with a much better safety profile. And then you have kind of these other meds that are non-stimulants that were never really designed for ADHD that we just found that we can use in them, which makes them attractive options for people that can't afford, that have insurance coverage issues, or, the question relating to Jamaica, some of these have been around for a really long time and may be a little bit more cheap in mass market, but also there's that behavioral side, and we can't neglect the fact that behavioral treatments can help and have a pretty decent success rate, maybe not as good as other things, but decent, like 50 to 60% success rate in and of themselves. And obviously that just takes a little bit of training for caregivers to help focus on. So there are options available, and I think that's where I think we've neglected to share that information to all our patients when they come in. A lot of providers just say, hey, here's what I'm going to do. And we don't really explore all the options. And so I just like to present all the options and make sure that if you guys are involved with this at any level, that you know the options as well, either to share with other people, to consider for yourself if you're involved with ADHD. And so that's where we start with the treatment options. So there are a decent chunk of options. maybe not all super successful, but all of them have a decent success, 25 to 50%, even at the lowest. So that means you have a good chance of having a quarter to help or half the kids that you encounter, even with these lower end options. And then obviously, as you kind of go back into the targeted ADHD meds, you have higher success. So we have a lot of options, and awareness is, I think, the most important thing, because there are going to be some patients that each one of these is a good option for. Okay. And so it's really about identifying that and recognizing that there's other things besides those initial hyperactive behaviors that we need to focus on. So let's say we do go the stimulant route, and I get a lot of patients that are on stimulants, and we try them and they get some success, but they can't quite get it exactly where they want. I feel better, I'm focused better, but then I can't sleep, or it lasts too long, or it wears off before I do my homework, or I have trouble in the morning. And so they just can't quite get the day right. And that's because there's this, I think, a lack of awareness, although that has improved as well, to understand how these meds actually work in the body. So we're going to talk real briefly that stimulants come, regardless of whether it's methylphenidate or amphetamine, in 3 different time categories. Am I doing the time myself? 15 minutes. Okay. So short acting means when you take the med, it's going to give you some effect for about 3 to 5 hours. All right. Now, that's not even a full day of school usually. So you're saying, well, obviously that's not enough if they're going to take it while they're at school. And so we have intermediate, which is 6 to 8 hours, which kind of covers the school day. All right. Maybe a little bit into after school. And then we have long acting, which lasts up to 12 or even longer. We go, okay, well, why don't we just put everybody on the long acting so we know that there's effect all day long? Well, because of the side effect side of things. The longer you're on it, the more risk of side effects, and especially those ones that maybe not be what we consider the serious ones, but they're the ones that are the most uncomfortable. Like, I never eat all day because I'm always on this stimulant, and I never sleep at night because the stimulant is still there in my system. And so we want to try to tailor it so you're just getting the impact when you need it, and it isn't causing the problems when you don't. Okay, so that's the challenge when you're using stimulants. So let's talk about all the stimulants we have. We have a whole bunch. So in the short acting, meaning these are pretty much what we call immediate release. You take it, it kicks in pretty quick, it works, and then it stops in about 4 or 5 hours or so. All right. So Ritalin, which is methylphenidate, which was kind of the original of all these meds, it's been around the longest. And you see some other brands there. I may not have every single brand. There's a whole bunch of brands on the market now. I may not have every one in all my slides, but you'll get the general idea. So we have, these are your methylphenidates. These are all fairly similar. I wouldn't say exactly interchangeable, but pretty close. And then we have the amphetamine side. They have short-acting ones as well. Adderall's probably been the oldest in that category, been around for a really long time. So these are all amphetamines, and they all work fairly quickly. So when you take these, this is kind of what it looks like in your body. So if we start on this left side over here, that's where you took the med. So it kicks in, and as time moves on this direction, you get more and more of the drug in your blood working. So you get more and more effect. So up here, you're getting a lot of effect from that drug. So this is your stimulant phase, right? You are amped up, right? You are able to focus and do everything. And then the drug starts to wear off. Okay. And then this arrow is about the time you would probably take your second dose if you want it to last more than 4 or 5 hours. Now, what's interesting is since these are meds that are working in our blood, the sooner you take it, the higher it goes. So if I take the med here, it's going to do that. Okay. If I take the med really early, it's going to do that. All right. So notice 2 things happen. I don't have as much of a dip the earlier I take it, and my second hump gets bigger and bigger because it's adding on to the first med. Okay. So we need to use this to our advantage to make it peak when we want it to peak and make it valley when we want the valley. So maybe this is actually a good time for the valley if that's lunchtime and there's no appetite suppression there. If you do one of these where you take it really early, yeah, you got to affect a long time, but you never have a gap. So maybe you don't eat until way down here because you're not hungry. So that's the challenge with taking the intermediate or immediate release, is you have to time it tailored to what your needs are. And that could be 2 or 3 pills a day. So they said, hey, we don't like 2 or 3 pills a day. Let's make a extended release form. So we have these intermediate categories. And this is where it gets a little funky. All right. So even though these are all considered intermediate release, they actually all release slightly differently. And so one of the lessons we're going to talk about is if your med is not working exactly like you want, you might need to switch to a different med because it's going to release differently and maybe match your day's need better. And that's the part that's been underutilized until more recently when picking these medications, because that requires us paying attention to our patients a lot and asking a lot of questions. And therefore, a lot of providers maybe haven't done that. So we really need to make sure we have a discussion with the kids and their caregivers and anybody involved to try to find out when is it we need effect and when should we not have effect, and try to find something that works. So just to give you an example of all these different intermediate release ones, notice that there's basically these top ones, which just list their strength, but these bottom ones give you a percent. So basically these bottom ones are all they've really done is taken 2 pills and put them in the one. So when you take that pill, you get the first pill first, and then a little bit later in time, it releases the second pill. So it's really like just taking 2 pills, all right? And so what that looks like in the body is exactly what it looked like on the other thing, except you don't have to take a pill here. This is all on its own. You take the pill, it works up, it starts to wear off, and the second part of it kicks in, and it does this. So you get that same kind of pattern, all right? But it's pre-designed. You can't alter it, okay? So that combination is fixed, meaning you better hope that this dip is where you want it to be, or it's not going to line up with what you need, all right? Now, when you go to some of those other options, it gets even wackier. I call this the cat ears, okay? So you get this kind of, this is Ritalin SR, sustained release. And so it kind of goes up and it flattens out and then it kind of goes like that. All right, so once again, not much of dip, but a much broader flat period of time where it's pretty high. So that one's kind of consistent, right? It kind of gets up there and it kind of stays in this zone and then it goes away. So that's great if you need attention during that whole time period. All right. And then we have some others that do this. Okay. So they're actually stronger later on and kind of flat in the beginning. All right. So really wacky. And then some that hit it hard first and then decline. So even though these are all categories of the same class of medications, you can see how they work differently in the body. And so sometimes you have to play around with it and try different versions of the medication to see what matches your body's need. All right. Now we have the long-acting ones. Now, these last for 12 hours or more potentially. The Daytrona patch, you have to take that off or it'll just keep working. Okay. So you need to take it off for after 9 hours of being on, and it still keeps working after that because some of it's soaked into your body. So these are really long acting. So I would say this is the category that gives us the most problem from a side effect profile, but it's the more convenient one, right? Because you're going to get a lot of action over a really long period of time. But once again, they're all real different too. So just because you aren't getting the effect from your Daytrona doesn't mean Concerta wouldn't work for you or vice versa. And so and the same thing for the amphetamines. There's the amphetamines here that are long acting. They work really strong and last a long time with not much in between. All right. So it's really about tailoring these to your patients. So some examples of what these long acting ones look like. So this one starts off pretty low in the beginning and then kicks in later in the day. And so that's osmotic release. So that's Concerta. Maybe that doesn't match your need. Maybe you need more stuff up front in the morning. Okay. And that one maybe affects your evening too much. Maybe you don't eat dinner very well because it's so strong later. So understanding that these meds are not all equal in how they work, I think is probably the biggest thing that we don't talk to patients about. And finding what things that work for them. So when it comes to ADHD, there's a lot of different options and you get different effects. And it's being aware of that it's not just like a Tylenol where pretty much any Tylenol is going to do the same thing. This is what most of the long actings look like in our body when we take them. They just last really strong. They don't hit as quickly, but they last a really long time. So it's hard to cut that off in a kid. So older kids, maybe that stay up later and don't run into problems, maybe that's better for them. But the younger kids that maybe have earlier bedtimes and need more sleep, maybe not a great solution. All right. So regardless of what path you go, you have stimulants, you should really pay attention to what you have to monitor, make sure there's no other disease states, and try to find the right formulation for the patient. And so If you're someone dealing with the ADHD, recognize you have options. If you're a caregiver, recognize you have options. If you're an outside entity that interacts with them, it's about awareness and discussing and maybe helping them identify when they have struggling times and when they have times where they can let the medicine fade away and get rid of some of the side effects. And then lastly, of course, monitoring is super important. You can't just start these and forget about it. We just saw that there's a lot of adjustments that may need to be made. And so typically you should see a patient every month or be seen as a patient every month until you find that good balance. And as we know, kids change year to year, their schedules change. And so a med that's worked for 2 years, it's quite possible it won't work in 3 years because schedules and needs have changed. And so sometimes you bounce around between different options if you're really trying to find that perfect fit for what you need or what the patient needs. Monitoring is really going to be tied to whichever class of med you chose, and we know what side effects go with that. One of the big things we talk about are drug holidays. A lot of times when they don't need quite that stimulation or that focus, you can go off the meds for short periods of time, holidays, summer vacation, things like that. But never, you really shouldn't stop any of these meds immediately, like dead on. Always talk to a provider, or if you're a provider, knowing which meds you should taper and which ones you don't need to. And some of that depends on what meds you picked. So some meds you probably shouldn't just stop right away. You should kind of wean down. Other meds, it's okay just to stop. And then we do recognize that kids change. Actually, there's a lot of evidence that in adolescence, ADHD symptoms tend to kind of decline, especially the impulsive, hyperactive side. That often goes away into adolescence and kind of different focus points and different priorities. Now, some of the inattention ones may still be there, but that means maybe you don't need the medications anymore, or the same medication or as much medication. So after a few years, trying to go without it and see how things are is recommended. Another thing we may not see happen a lot. All right, that's what I've got. I know I kind of was talking fast. I'm a fast talker. I am not on ADHD meds, but I sure sound like I am from a stimulant point of view. I did have 2 sips of Diet Dr. Pepper. Maybe that's what did me in and made me talk fast. But I'll more than willing to take questions if we have them. I don't know if we do, or just I'll talk about whatever you want to talk about. I'll talk about why rainbows are the colors they are, or why the sky is blue. I'm game for anything.
We did have a question, Dr. Parker. One participant asked, what is causing the current ADHD medication shortage, and what are your recommendations for patients?
So the thing that's causing the medication shortage is the same thing that's causing a lot of medication shortages and car part shortages and like everything else. Med use is very high. The demand is high. The factories that make them, so we've lost workers. Factories have shut down because of COVID. So I hate to blame everything on COVID, but that has a real big part still of that. In addition, some places were converted to do other things. Now, ADHD meds are a little different. Like some medications, like some of the hormones, they have to grow those. So that takes a while, and there aren't as many plants. But ADHD meds, it's about choosing what they're going to manufacture. Most of these companies use the same plant, and they manufacture a batch of one type of med, then they totally reconfigure it, and then manufacture a totally different med that they make. And so that's, since most of these meds are made by large companies that make multiple medications, and they aren't just an ADHD medication company, they're cycling through the meds. And there's been in addition to having a reduced workforce and not all the factories up and running fully, we've seen an expansion of new medications for other disease states that are now taking priority over the manufacture of the ADHD meds. Also, there's some issues with ADHD meds because the stimulants are controlled, and there's been some diversion issues in some areas. And so that's reduced supply as well. In other words, a big truck carrying amphetamines for ADHD gets stolen so it can be sold illicitly. So there's lots of little parameters there, but fundamentally it's just we just can't keep up with demand, not just for this medication, but for several medications that are out there. I don't know if that answered your question well enough. I don't have a good rationale other than that. As far as options, Well, once again, we have a lot of stimulant options. So bouncing back and forth, while may not be ideal, it is definitely an option for what is available, since there are so many in the same categories, especially the stimulants. We have all these methylphenidates, we have all these amphetamines. So trying other ones that are available. Now, they may not be, because of the release, if they're intermediate or long, they might not perfectly match your needs, but with a low dose, at least you get some benefit. Maybe not the full benefit you would have had on the med that you found that you liked. Or also looking at trying some non-stimulants that might be more readily available. Some of them have been used in adjunct with the stimulants anyway. So trying them couldn't hurt. So they might have greater availability, especially some of the lower ones lower on that list, like clonidines and guanfacines and things like that. You kind of have to maybe mix and match when there's shortages like this. Also, if you haven't tried behavioral therapy, maybe it can round out the edges for when you can't access the meds that you want, or you can try a med that maybe isn't quite as effective, but has some effect, and then you supplement that with some behavioral therapy, which I hate to say it's behavioral therapy. It's really about behavioral skill sets. It's not therapy in what we traditionally think is therapy. But that could be an adjunct, a temporary, bypass until supply regains itself.
Well, we had several other questions. I'll go through them and you can answer any of them, any or all of them that you'd like to. Someone asked about, in addition to drug therapy and behavioral interventions, someone asked about what natural interventions, or if there were any natural interventions.
Yeah,
someone else asked about art and music therapy. Someone asked about behavioral therapy for older children. So many questions.
Yeah. So actually, when I teach this in the classroom setting, I do talk a little bit more about some of the other stuff. And I probably should have mentioned it, but I'm just kind of rambling on about. There are a lot of so when we think about ADHD, we have tied it to some environmental factors, and there are also some food. So some common things that we recognize. Now, this isn't for everybody with ADHD, but we know some folks with ADHD it's made worse by things like certain dyes. Like I know yellow and red have popped up a lot in patients. Chocolate, smoking, missing some, peanuts. And that's not all. Like everybody isn't affected by all those, but some kids are affected by some of those. And so there's a lot. I've known patients that also really kind of focus on the diet side of things, in trying to work with that. You want to talk about more of the homeopathic or herbal or over-the-counter route. Not a ton of evidence, and so I'm not going to say you should do these things, but things that typically work on those same things we talked about, like anxiety and depression, might have an impact here as well, because there's a strong overlap between those and ADHD and kind of the way the chemicals used in the brain for those. And so things like that could also help. When it comes to behavioral therapy, that's a pretty broad category. Like I said, the initial one is what they call parent therapy, parent training. But there's ones other than that. So someone mentioned music and things like that. They are actually brought up. The problem with those, and I don't want to say problem, but from a provider point of view, is they're not strongly recommended, simply because there isn't a lot of evidence to say yay or nay. But what are the side effects to those? Nothing. So I would say try all those things. So yeah, music therapy, animal therapy have been shown to help these kind of things. But the problem is nobody's doing these big, huge studies to show, hey, look how much better they are. And it's hard to show that. And so that's why they don't carry the weight of what a lot of providers are focused on. But there's no reason to think that they can't offer benefit. I don't know if I covered all the little things that you threw out there. I feel like I covered a lot of them. I might have missed one. I don't know. Did I miss any?
You did cover quite a bit. Somebody was asking about ADHD in older children, both medication options and behavioral intervention options.
Well, I guess it depends on what you mean older children. So honestly,
older than 15.
Older than 15.
Mm-hmm.
Well, technically everything I said applied. And in fact, we now see what we call adult ADHD. There's a % chance that if you have it as a child, it will carry over. It's not as high a percent. In other words, like everybody doesn't carry it with them, but some do. And so honestly, the treatments in the adult world are really not any different than the kids world. The only difference is your doses may change because you're a bigger person, and a bigger Ziploc bag needs more water to fill it up. So a lot of times the doses are increased or things like that. Behavioral therapy, it kind of takes a different tact. So a lot of the parent training, like if you're dealing with an 8-year-old, you're training about certain like kind of reinforcing behavior, but with an adolescent, it's almost on them. So there's a lot of skills and compensations, like teaching them how to deal with scenarios, which doesn't hurt anybody really, to learn how to deal with stress, how to deal with challenges, and kind of gives them what I would call coping mechanisms. And so that's what a lot of the older therapy is tailored around, is what we would call coping mechanisms, teaching them even physiologic things like how to control your breathing, can bring focus in better and stuff like that. So there is behavioral therapy for older kids. It's just tailored to a different style, more of those coping things. And so once again, fairly underutilized, but effective.
All right. Well, thank you, Dr. Parker. We actually had we had a couple other questions come in as predicted. This is, of course, a high interest topic. And so I'll share one more of those with you, and then we'll provide closing remarks in our chat box so that any participants that need to conclude the presentation, they'll have that option. But someone asked, is changing dosage or med type the only way to help a child having tics?
And I'm going to say no, because honestly, the big thing there is to figure out why the tics are occurring. Now, we can just to say, oh, they're on a med, let's blame it on the med, but it may not be the case. The med may be magnifying or exaggerating something that else is an underlying cause. So it is quite possible that there are several underlying causes that can cause that. And some of those could have nothing to do with medications or altering the medication. So I think the first step when you see that particular side effect is to get more investigation, because it could be a lot of different things. And so some of that may be totally once again, behavioral side. It could be not even an ADHD med. It could be something totally different. There are actually some other disease states that can precipitate that aren't psychological disease states. And so I would want to evaluate that. And so that one's a fairly unique one, right? It could be a lot of different things. And so just tweaking the meds means you're only thinking it's the meds. And so when you see that side effect, you probably should have it kind of investigated a little bit further.
Wonderful. Well, thank you. And thank you so much for your time this evening and your presentation. Again, an area of high need and certainly relevant interest for participants. And I know that this is a topic that's frequently viewed on our website. And so for those of you that are not aware and wanted to share this resource with other students or colleagues, you can access previously presented community workshops, which will include this one at our website. It's wtamu.edu/CLD. If you need a continuing education certificate for tonight's workshop, please complete the Google form that's embedded within the chat box, and be sure to add your name and email. And the email address that you enter into the form is the email at which you will receive that continuing education certificate. We also strongly encourage participants to complete our survey. We use this survey information to analyze who is our audience, what your preferences on timing and delivery format are for these workshops, as well as preferred future topics. And so please take the time to provide that feedback, because we genuinely do use it for future planning. And then we want to encourage you to register for our next community workshop. That is coming April 3rd. And it is perfect timing. The topic of that workshop is tips to manage test anxiety for students with learning differences. And we know that that is an area of great need as we come into the April and May season if your child or if you are teaching in a K-12 public school. And then if you would like to receive updates or be a part of our email list, send an email to wtamucld@wtamu.edu, and we would be glad to add you to our email list for future communications and updates. So thank you all for your time this evening and choosing to join. And again, thank you so much, Dr. Parker, for your expertise and insight on this much needed topic.